Indurkar, a specialist in endocrinology with a rich experience of 35 plus years. Sir has published several research papers in India as well as in abroad. He's been a member of a prestigious medical associations throughout his career, and through his center he has conducted several patient education camps and CME programs aimed at providing learning opportunities to physicians and other healthcare.
Thank you, Manish. Thank you all of the team of known artists who are trying for this session. And I also thank my co-speaker, Dr. Mayura, my friend, Dr. Deepak, and all of you who have joined. What I have decided after discussing with my co-speaker and everybody that we'll try to finish this in about 1 hour and we'll restrict to practical points. If there are any questions, queries, comments, you can stop us and give it, so that there is no need to wait for question and answer session, but that would be there. So we'll make it quick and fast so that we can finish as per our planned time. On table we have a small insulin reference booklet that contains everything about insulin, and you can go through that whenever there are any details are available. In next 15 minutes, I will cover my presentation in about 3 First, we will discuss science and legacy of insulin, then types of insulin and practicalities of insulin. Last year, we celebrated 100 years of insulin discovery, and I hope most of you know the history, which is very interesting, and each and every person which was involved in this, patients which were involved in this initially, they give us a very good, interesting story. One should go back and try to read it. Great, fine. We are well aware that when insulin was not available, death was a stand for every diabetic once she or he was diagnosed. Once insulin was made available, the lifespan improved, the quality of life improved, and for this discovery, these 4 guys, Banting, Best, were initially awarded Nobel, and they shared subsequently, Banting with Collins and Best with MacLeod. We all know what is insulin. It's a hormone. It works through various modalities, and when it is effective, these are the areas where it finally works and sees that the metabolism at multiple levels is positively affected. Coming down to other important aspects of insulin, it is an anabolic hormone. If you give insulin to any patient who is emaciated, will gain weight, will have positive things, his appetite will improve, and it's a wonder drug. On the top of only glycemic benefits, it is anti-inflammatory, antioxidant, anti-thrombotic, cardioprotective, glucose lowering, I have already discussed, and anti-lipolytic action. Physiologically, this is what is expected from a long-acting basal insulin and short-acting preprandial insulins. Now the most important point, if you look at anti-diabetic available modalities, oral, injectable, in this 100 years, there are n number of anti-diabetic therapies came in, but insulin is the most powerful, most effective, brings down A1C between 2 to 5, and no other drug is so powerful. So still it is at the top of the list. And this insulin when came was probably a very crude, simple insulin. The quantity which was injected to the first patient was in mLs, 20, 15, 30 ml. They had their issues with that. The point about it. And as the time passed, we had lot of changes in structure, mode of action. And as I said, with 100 years of legacy, we have multiple insulins. It started with animal and human insulins available, short acting, intermediate acting, then long acting. And as subsequent days, their purity started improving. They became monocomponent, and of late, the younger generation probably sees predominantly purest human insulins. They have premixed, there are short acting, there are ultra fast acting, long acting, and multiple insulins, which all of us know, and the details are there in the insulin reference. Another important point I would like to quote: we had three strengths of insulin about 2 decades back: 40 IU, 80 IU, and 100 IU. But 80 IU have gone about 2 decades back. Globally, it is only 100 IU, but in India, we have both for some technical reasons. So whenever you use 100 U insulin, see that the syringe is 100 U, and whenever you use 40 U, we should have a 40 U insulin syringe. These are multiple available insulins where we can use them, how they work. It's a long readable matter. I think all of us know it, but if you want any detailed information, we have an insulin reference booklet with us. My request is, one, depending on eating pattern of your patient, you have to choose insulin. In an active patient, a patient who is eating 3 times a day, use appropriate insulin, whatever choice you have, premixed, basal plus, basal bolus, and try to coordinate eating pattern and insulin injection, and that only will give you a very proper control. There are 2 caveats: hypoglycemia and weight gain. These should be answered whenever you want to treat a patient. As we go ahead, the major problem with insulin is how we are going to use it. So, depending on the various criteria, higher the A1C, more symptomatic is the patient, you have to select insulin. A patient has 8.5 A1C, he is asymptomatic, you can still use other modalities, but every thin build, emaciated type 2, he has multiple symptoms of muscularity, and he has weight loss. I think all these patients should be shifted on insulin. Other important indications when we discuss insulin is uncontrolled type 2. Type 1, there is no question. In hospital management, remember every patient who is admitted in hospital from associated comorbidities should be shifted on insulin. And when they go home, please suddenly do not stop insulin and shift them to pre-admission oral drugs. Continue insulin, monitor for a couple of weeks, and once they settle down, either you can change over or continue. After COVID, this has happened. From COVID hospitals, on insulin patients were treated and then they were discharged, they were shifted to oral drugs, and they again went into severe hyperglycemia. Surgery, stress hyperglycemia, infection, sepsis, DKA, HONK, pregnancy, CKD, and where OADs are contraindicated are the patients where we must put them on insulin. Titration of insulin, there are algorithms, there are various formulas, but your patient's glycemic levels, their eating patterns, coexisting comorbidities, risk factors will decide what, when, and where we are going to use it. Storage of insulin is another area which we all know. We have to teach our colleagues, our patients, that how to preserve, store, and carry insulins. Recommendations are very clear, and most of the drugs, they can go along well with insulin. Only when you are using glitazones, they are quoted that you can reduce the dose of TZT by 50 units. I would go otherwise. Once the diabetes is controlled, you can reduce the dose of insulin by 50%, and there are many situations you can withdraw insulins if they are on glitazones. Another limited care for this is, and this is how we can use insulin in various aspects. As I said, there are two limitations, hypo and weight gain. Hypoglycemia has to be properly defined, looked at. You must explain this to every patient and his family. Try to detect it. And if you are properly giving insulin and diet, mostly they will not have hypoglycemia. So, management of hypoglycemia would be very crucial, which includes these four things. So once you choose insulin appropriate to patient, keep a watch on weight gain and hypoglycemia. It is very simple, easy to manage hyperglycemia, change the dosage of insulin. So in brief, we can say that among the antidiabetic, this is the most powerful drug. Based on the action of plasma glucose levels, they are broadly divided into these three areas. RSSBI and all other authorities, they recommend insulin in most of the patients who are uncontrolled. One practical hint, never use premixed with basal insulin. You either follow basal plus or basal bolus, or you stick only to premix. They are never interchanged. Please do not use them. With this I stop. Thank you very much. I request Dr. Mayura to take up the second presentation.